All right. Good afternoon, everyone. Welcome to It's Worth a Shot. Welcome back after the 4th of July holiday. We hope you guys all had a safe and wonderful holiday. Today, we are going to be talking about adverse drug events. Two of my colleagues from Mountain Pacific will be presenting for us today. So let's go ahead and go to the next slide. So we'll skip over the disclaimer, because as I mentioned, our Mountain Pacific employees will be presenting for us today. We do have a lot of updates and reminders today. So the Centers for Medicare and Medicaid, CMS, they are doing a rural health hackathon. One of those presentations will be in Bozeman, Montana. So if anyone is interested, we have the link to the survey. You just have to fill out, there's a 5-minute interest survey, and it is due by July 12th. So again, if you guys are interested, make sure you guys take a minute and get that filled out before you miss the window. Also next week, the NHSN is doing a virtual post-acute care training. It is a couple of days long, so make sure you guys take a look at that. The registration is open right now. There's a lot of really great topics on the agenda. Should be some good training. So go ahead and go to the next slide. We have some additional updates and reminders. Check out our new Mountain Pacific blog post. It's from Brittany Hull. She's one of our activities directors out of Wyoming. So take a look at that. And then just as a reminder, we sent this out on the listservs, but there are some new training modules from QSEP. It's CMS targeted COVID-19 training. One is on caring for residents with dementia, and the other one is on emotional health. That is free training, great education for your staff, so make sure you take advantage of that. And then just as a reminder, there is a new QSO memo. Again, we sent that on the listservs, but just in case you missed it, we'll have the link on the slide deck. So let's go ahead and go to the next slide. So just as a reminder, we appreciate all of you guys' feedback. So make sure that you fill out the evaluation at the end of the session today. Again, we really appreciate your ideas, and we want to make sure that we're meeting your needs during our sessions. So we do have a polling question for today, so let's go ahead and launch that. Do you have any residents that have expressed interest in quitting smoking? I'll give you guys a minute to fill that out. All right, we can go ahead and end the poll. It looks like a good majority are no. We do have some different resources, and there's some education on our website as well. So make sure you guys take a look at that, and we'll be sharing more in the future. So stop sharing. And now I will turn it over to Kyla and Ray to talk about adverse drug events.
Thank you so much, Callie. And I will just start out by saying during our break last week, for those folks that are in Alaska, I did have the pleasure of going to the car launch up by the Matanuska Glacier, which is a very cool event. If folks haven't heard about it, they launch cars off a cliff down to the riverbed, and it's quite the event. So yeah, I enjoyed last week being off, and I hope you guys had a nice 4th of July as well. So now we get to talk about adverse drug events. So this is an initiative, one of the initiatives that's in our current contract with CMS, is to track and hopefully prevent adverse drug events. So we can go to the next slide. So just kind of as an intro, I did look at a couple resources looking at just adverse events in skilled nursing facilities, not necessarily related to a drug, but could very well be related to a drug. And as I'm sure many of you on this call already know, there are lots of adverse events that happen in this setting. And what we know about them, just looking at numbers, is that many of them more than 50% in most of the studies that are out there are preventable. So this was a report that looked at within the first 35 days of a skilled stay, and they found that 60% of adverse events were preventable. We can go to the next slide. So this is another one that was looking at folks when they were actually transitioning from hospital back to the nursing home. And we're seeing similar results here that 70.4% were preventable events, including things like skin tears, pressure ulcers, and then falls. And that's the one that kind of stands out to me as potentially being related to a medication. It could be related to a medication. It could not be related to a medication. But always something that we need to consider is, could it have been a medicine that this patient was taking? And so that's kind of what the focus of the rest of the presentation will be, is looking at definitions of adverse drug events, and then looking at the high risk conditions and medications that can put patients at higher risk for these events. We can go to the next slide. So it's really hard to define adverse drug events. So it's a very broad term. And if you look at the Institute of Medicine, they say it's any injury resulting from medical intervention related to a drug. But then it goes even further to include kind of underarching terms, I guess, such as medication errors, adverse drug reactions, allergic reactions, and overdoses. So if we look at the definition of a medication error, it is inappropriate use of a drug that may or may not result in harm. And additionally to that, this can include errors during prescribing. So if something was prescribed in an inappropriate dose for that patient, transcribing, dispensing. So if we give the patient the wrong drug, we actually dispense something wrong. Administering, so we give the patient the wrong medicine if we're in the setting where we're administering medications. Adherence, which is interesting. So if a patient isn't taking their medication as they should be, this could be considered a medication error. And then monitoring. So if we're incorrectly monitoring drugs, especially those that might be like a narrow therapeutic index drug where we needed to get labs to monitor that therapy. And then if you look at adverse drug reaction, this is basically something that we might expect. So this would be something that would be listed in the package insert as a possible drug reaction or a reaction to a medication when we're giving it in a totally appropriate situation and at a normal dose. And we can go to the next slide. So basically this kind of just shows that there's overlap with these terms. Obviously, all medication errors do not cause harm. Many of them are caught before they actually cause harm to a patient. But if they do cause harm, they fit in the adverse drug event category. We can go to the next slide. So just looking at the magnitude of the problems, so we know this is a huge thing that's happening across our healthcare system, but specifically this looked at emergency department visits, and 5% of hospitalized patients also experience an adverse drug event. And if we look at medications, people are taking a lot of medications, especially our older folks. So 65 and older, they're going to be the biggest consumers of medications. Obviously, as we get older, we have more conditions to treat, and things are going on as our body gets older that we need medications. And about 20% of people in this age group take at least 10 medications. We can go to the next slide. So this is just kind of an overview. I'm not going to read all these statistics, but it was looking at patients in the 40 to 79 age group, and just how many of them had had a prescription in different settings. So provided in either the physician office, the percentage of visits that involve drug therapy is 71.9%. And similarly, if we look at hospital emergency department visits, 76.2%. And if you see those therapeutic classes that I'm kind of seeing as a theme, analgesics is going to be one of those top. And if as I move forward and talk about the highest risk drugs for adverse drug events, analgesics, specifically opioids, is going to be one of our focus. You can go to the next slide. So this was a report where Medicare claims were reviewed and potentially preventable events related to medication. And so if you look, you'll see that number one is opioid related or psychotic medication, hypoglycemia, number two, ketoacidosis, bleeding, and thromboembolism. So all those adverse events are related to our highest three high-risk drug categories that we're tracking with our metrics, which Ray is going to talk about that more specifically, how we're tracking those in his presentation. We can go to the next slide. So what are the risk factors other than being on these high-risk medications, which I will talk about a little bit more? Polypharmacy. So polypharmacy just means being on many medications, kind of alluding back to the fact earlier, those older folks are taking a lot of medications. Older age, just because as we get older, our body can metabolize drugs a little bit differently, maybe a little bit slower, and just the dynamics and pharmacokinetics can change as you get older, as your body composition changes, and your kidney function may decline, etc. Also, pediatric patients are at higher risk. And then anybody who's on one of the four high-risk medications, they account for 50% of emergency department visits for adverse drug events. And this was specifically in Medicare patients. So the four high-risk medication classes, we can go to the next slide, include these three on the slide. So anticoagulants, diabetes medications, and opioids. That statistic also included antiplatelet drugs. So that would be drugs like clopidogrel or Plavix. And those are actually not a class that we're tracking in our current metrics. So that is something that's important to know, but they do still have the potential to have a higher risk of adverse drug events. And we can go to the next slide. So this is just some data, Medicare data, percentage of patients they're having an adverse drug event. We have this broken down by our states and by the three high-risk drug classes. And as you can see, anticoagulants are actually the highest in all of our states, except Wyoming, which has a higher percentage of adverse events related to opioids. So just some interesting data. This is kind of tracking over time. This was in 2022, and we continually get updated information. But I do think this highlights the fact that I think focusing on anticoagulants and really looking at those as a source of adverse drug events is really important and could be a really good point of intervention. You can go to the next slide. So just a couple of tools. One of them is specific for skilled nursing facilities, a way that you can kind of start, if you haven't already, looking at adverse drug events, and then another tool from CMS. Go to the next slide, and I've just provided a few resources. This National Action Plan for ADE Prevention, this is kind of where the work that we're doing under our contract with CMS comes from, with all the definitions that they have in that report. There's some really nice high-risk medication guides that I would encourage you to check out. They are pretty extensive in the information that they have on them. They can be for consumers, but they could also be used pretty readily by healthcare professionals. And then just some resources about medication reconciliation, and specifically looking at those anticoagulants, or the newer class of anticoagulants, which is the DOACs, or the direct oral anticoagulant drugs, an interaction guide that would be really useful if you have patients that are taking those medications. And I will turn it over to Ray to talk about kind of some more specifics in the methodology of how we're tracking adverse drug events in our contract.
Thank you, Kyla. Yeah, so I'll be talking specifically about the metric that CMS has defined for us. Here at Mountain Pacific, we refer to it as metric 2.2. And as you may have guessed, we're going to be looking at anticoagulant, anti-diabetic, or opioid ADE hospital encounters among nursing home residents. So just let that sink in for a moment. So we're looking at fee-for-service nursing home residents who have a prescription for an anticoagulant, anti-diabetic, or opioid, and then they have an adverse drug event and are sent to the hospital. So we're going to start breaking that down a bit and looking at what our potential population is. Now, CMS does split this metric up into short stay and long stay distinctions. For today, we're going to largely ignore that because the numerator is essentially the same between the two. And again, we're looking at ED visits, OB stays, and inpatient admissions for an anticoagulant, anti-diabetic, or opioid ADE. So that being said, let's focus in on our numerator. We're going to see what that's done over time. But first, we'll touch on our data sources. So CMS looks at Medicare claims for this. Obviously, they're looking at Medicare fee-for-service bennies. So they're going to use Part A, of course, to analyze those hospital encounters for ED visits, OB stays, and inpatient admissions. Part B claims for those prescriptions. And then they're going to use a combination of what they call the BIC tables, so beneficiary information on the cloud, and the MDS tables to identify nursing home residents and their demographics. And finally, the FDA drug files, they'll use those for like NDC crosswalks and putting together reference tables for the specific medications that they list under anticoagulants, antidiabetics, or opioids. All right, next slide, please. Now, starting off, like I said, we're looking at fee-for-service Medicare bennies that happen to be nursing home residents. And forewarning, we're going to try to get into the mind of the statisticians at CMS here. So if you want to tune out, that's fine. But that being said, I've broken down the anticoagulants and anti-diabetics on this page. You'll notice under anticoagulants, you'll see some pretty typical things like warfarin. Under anti-diabetics, you'll see insulin appearing in there quite a bit. You know, by and large, these lists make a lot of sense. And if you go to the next slide, you'll see opioids. And you'll see, again, pretty typical things that you might expect on an opioid list. You'll see oxycodone, fentanyl, and then some relatively minor inclusions and exclusions on the bullet points down there. Now, I won't read these out to you because, frankly, I can't pronounce every one of them. But that being said, these are our starting point. So we're going to look at Part D claims. We're going to look at the Medicare fee-for-service bennies who have a prescription for one of these. And then next slide. Then we're going to go into Part A claims. We're going to look for those inpatient ED and observation stays. And the way we're going to query that is we're going to look at claims using ICD codes. So CMS predefines the ICD codes that they want to include for our numerator beneficiaries. There's 316 unique codes. And then they're specific to each category. So there's going to be of those 316, there's going to be a subset specific to Medicare bennies with an anticoagulant prescription, and then a list specific to the anti-diabetics, and a list specific to the opioid group as well. I should also note that these ICD codes, they have to be in the primary position on the claim. So they have to be the primary diagnosis associated with that claim. Even if one of these ICD codes that's included in the reference list is in the second position, that beneficiary and that claim are not included in this metric. So they're really getting narrow into the group of nursing home residents they want to look at. And down below, we can see just some quick examples of the ICD codes we're looking for. So anticoagulants, for example, I-609, non-traumatic subarachnoid hemorrhage, anti-diabetics, T383X5A, the adverse effect of insulin, and opioids, T40601A, poisoning by unspecified narcotic. So we're going to have to see one of these ICD codes in the primary diagnosis position on a Part A claim. And if you go to the next slide, we're going to continue with our theme of ICD codes. Now, of those 316 codes, there's a handful that are frankly kind of questionable as to their relevance. And so I've included some of those here, and really they're the R4 codes as I described them. Looking at, say, R403 or R404, those tend to get a little bit generic. Just because somebody has an opioid prescription they happen to be in a persistent vegetative state and there's an adverse drug event, is that a medication error or, the fault of anybody? It may or may not be. These are, like I said, pretty generic. Even looking at the bottom of that list, R443, looking at hallucinations unspecified. Is that specifically caused by the prescription? I would say it could be questionable. But that being said, CMS defines the rules here. We play by the rules and we go out and do our best. So next slide. So how has Mountain Pacific performed with this metric 2.2 over time? Frankly, we've had some mixed results. So what we're looking at here is our numerator values over time. So you can think of the number of beneficiaries with an anti-diabetic, anticoagulant, or opioid prescription who are having adverse drug events. And I do split this out by short stay, long stay. So that orange line shows you the long stay residents with ADEs over time, and short stay is that blue line. And on average, for our long stay residents at any point in time, there's about 84 residents out there that are going in every month with an ADE. And for short stay, it's about 42. And I should note that these are across all 4 of our states that we work in and the Pacific Islands. So, for example, we're working at 42 on average short stay residents spread over 4 states in the Pacific Territories. So it's a pretty small group of people. Oh yes, and Kyla put into the chat here, hospice patients are excluded from the metric. Yes, excellent point, Kyla. So, we haven't had any major increases or decreases with these metrics. It has been a tough nut to crack. But that being said, we do appreciate everyone on this call and your efforts to look at these ADEs that we brought up, and perhaps we've even contacted your facility and talked through a couple of them. Without your help, we wouldn't be doing nearly as well with this metric, I don't think. But that being said, we can move to the next slide. So, of those claims that we see coming through for nursing home residents that have a prescription for anticoagulants and opioids, what we see on the screen here are the top 10 ICD codes that we're seeing, and these are in order. So anticoagulants on the left there, the most frequently occurring ICD code is D649, that's anemia unspecified, followed by R319, hematuria. And then you can go down the list and see the slightly less frequently occurring codes. On our right, we've got our opioids and the top 10 most frequently occurring ICD codes. And again, these are in order. And unfortunately, one of those R4 codes I mentioned earlier is our most frequently occurring ICD code, that R4182, altered mental status unspecified. It's unfortunate, but that's the way it is. Followed by J9601 and another R4 code, R410, disorientation unspecified. So I did not include anti-diabetics on this sheet. The sample size was extremely small. And as Kyla mentioned earlier, actually anticoagulants are our most frequently occurring group here, followed by opioids. So really it is anticoagulants, opioids, and then anti-diabetics in that order that we see these claims coming through on. And then go ahead to the next slide. So that will wrap it up for me. If there are any questions out there, feel free to come off mute or put them into the chat. If there aren't any, Callie, I'll hand it back to you.
Okay, we'll wait just a minute to see if anyone has any questions. I'm not seeing anything in the chat. All right, as a reminder, the link for the evaluation for today is in the chat. Also, you can find all of the recordings for the It's Worth a Shot and the slide deck on our website. So reach out to your account manager if there's anything that we can assist you with, or if you need help finding those. And we will see you guys all next week. Make sure you join us on Wednesday, July 17th. Same time, same place. Thanks, everyone. Have a great day.
Thanks, everybody.
Yeah, thank you.
Bye.
Bye-bye.